never was fat transfer ever mentioned.
Yeah.
And as a result of that, you could park a small car between my boobs.
Oh, no.
Welcome to the Joy Tuck Club, the podcast that celebrates the beauty and diversity of transgender individuals and identities. I'm Rachel, my pronouns are she, her, and with me is my wife and co-host, the beautiful Phoebe.
Oh, also she, her.
What are we doing today, Phoebes?
Oh, we're transferring the fat, perking up our pecs, and deciding if we want to go over or under the muscle as we talk all things BA with Giuseppe Di Taranto.
Really? How exciting. I love Pulp Fiction, but I had no idea he liked the 80s.
No, not Tarantino. Giuseppe Di Taranto. Top surgeon for top surgery at London's Chelsea and Westminster Hospital.
Of course, that does make more sense on a podcast about gender-affirming care.
Mm-hmm. Oh, also, apologies to our listeners for the delay between this and our previous podcast featuring Frida Wallace. We were both consecutively struck with a lurgy that made talking almost impossible. But we are back, full-throated, ready to go.
So with that, let's start the interview.
Dr. Taranto, are you ready for a deep probing?
Very ready.
Well, firstly, welcome. Thank you for joining us today. We're going to start with some easy questions. What made you want to become a surgeon?
So that's an interesting question. I can tell you about a memory I have from my childhood and a funny story that my parents and all my relatives keep on saying to people around me, or especially if I introduce to them new people. I am the last sibling of three. I have two older sisters. And when I was born, my mom was 45. So it was a big surprise. It was an Easter egg surprise. And while I was growing, she decided to take out from the storage, to take out all the toys from of my sisters. And, my sister, they had a lot of dolls. And I was playing with the dolls, but I was playing in a strange way. I was cutting pieces and readjusting them, pretending that they were delivering, and then making up a baby. And then while I was growing, while I was doing my schools, I got very passionate about anatomy, physiology, and biology. And then I realized that probably that was my path, my future.
Yeah. So what drew you to trans healthcare, gender-affirming care? What drew you to that in particular?
At the moment, I am a consultant plastic surgeon at Chelsea Westminster Hospital. Plus, I have my private practice. Chelsea and Westminster Hospital 3 years ago has been commissioned by the NHS to open a new center for gender surgery. When this service started, I was working at St. George's Hospital. I had a consultant post at St. George's Hospital. And, I've always been fascinated and interested in gender surgery. I had some experience before because I work in Taiwan. I attended a fellowship in microsurgery in Taiwan. Mm-hmm. And there I performed gender surgery with a colleague from Thailand. So that was something that always fascinated me a lot. So when the advertisement for this post as a consultant plastic surgeon leading the Center for Gender Service came out, I was very intrigued to apply, and I did it. And I must say that was one of the best decisions in my life. I'm specifically the lead for the chest reconstruction service, but I collaborate with all the other services. My background, of course, is medicine, and I'm Italian, as you can guess from my name and my accent. It's very easy to guess. I come from a small town in the southeast of Italy. So you know that probably most of you know that Italy is considered to have a boot shape. Mm. So my hometown is the tip of the hill. So it's far southeast of Italy. It's beautiful.
Yeah.
But there was no school of medicine in that area. So when I was 18, I moved to Rome to start studying medicine. I finished all my medical schools. I did my placement program. This is my foundation program. I got a post for as a trainee in plastic surgery in Rome. And then once I finished my training, I had the chance to go for an experience abroad. I already had a post as a PhD in Rome, and I had the chance to go abroad to further hone my skills. And when my professor asked me, where would you like to go? I didn't have any doubt, because I knew that if I wanted to become a good reconstructive surgeon and a microsurgeon, I had to visit Asia. Specifically Taiwan and Japan. They are considered the motherland of reconstructive microsurgery. Is where all the most advanced technique have been invented. So I applied for a fellowship in Taiwan with Professor Un-Chi Cheng, who is a superstar, a living legend of reconstructive surgery. I was so lucky to spend more than a year with him, 1 year and a half. And I had the chance to see, living legend of plastic surgery operating, and seeing as well young pioneers of the field. And I must say it was the best time of my life. I was working very hard. We were operating from morning to night. It was very rewarding, because I was learning a lot. I was doing a lot of surgery. I was learning from people from all over the world, because these centers are very renowned for microsurgery. So lots of international fellow attend the fellowship. And so I had the chance to interact a lot with professionals from all over the world. I had the chance to learn a lot. I had the chance to develop a lot. And as well, I had the chance to travel a lot. Taiwan is right in the middle of Southeast Asia. And I visited so many countries, and I was amazed by the culture there. During that experience, I've also had the chance to work closely with a Thailandese surgeon, Nemchat Sitpaul, who is my friend now, and she specialized in gender surgery. She performs both masculinizing surgery and feminizing surgery, and that was an inspiration for me. It's a big inspiration personally, because I saw with her how this surgery can change people's life. Actually, I don't like to say change. I like to say complete people's life. Patients, sometimes they feel like there's a piece of a puzzle missing, and this surgery might give them the solution, might give them something to feel complete, and to feel more congruent with what they feel.
Do you think if medical students were taught more about gender-affirming surgery, then more people would want to go into that field?
Training and education is important for two different reasons. First, because any trans patient who approach the healthcare system, any healthcare system, should be treated in a way that is fair and that is appropriate for that type of patient. So any medical professional should know about pronouns, should know about the needs for gender surgery. They should know that if they had a type of surgery, maybe a catheter is not the best option, or another type of catheter can be the best option. These are simple information that any medical profession should have in their hands. And second is important because we are desperate to have more people to work in this field. It's a matter of priority to teach students and to teach trainees about gender surgery and gender healthcare in general. I believe that if people really knew and really saw what this surgery can do, I believe that we will have a lot more professionals in the field.
Yeah, we've got that from a lot of the surgeons we've spoken to. That they've said how rewarding it is to see that they've changed someone's life. You don't get that in some of the other fields. So
no, of course, especially with surgery, there's also a sort of transformation, either in some symptoms, either in the disease, or either if it's plastic surgery in the outside, I would say, face of a patient that, of course, reflect the inner side.
Mm.
So surgery always make a big impact. It always make a big change in the life of the patients. But this type of surgery really completes the patient, empower the patient to be themselves.
Yeah.
I love the phrase life completing surgery. We're going to absolutely steal that for the book.
Okay.
Oh, yeah.
Just mention me.
Yeah, sure.
No. I'm going to do more than that. Giuseppe, what are the differences between BA for cis people versus BA for trans people in the process and the surgery?
That's a good question. Many providers, they approach transgender surgery and transgender healthcare as they would do with cis patients. But there are a lot of things that we need to consider and take into account. First, the evidence-based medicine, which is, of course, our lead to deliver healthcare, is based mainly on data coming from cis patients. Regarding breast enlargement, there are tons of studies about the outcome of breast surgery in cis patients. There are not as many studies for transgender patients. And very naively, professionals might think that, you see the result of a study, which is a good study for cis patient, and they just replicate it, translate it to transgender patient. I believe that is not the case. We are meant to follow evidence-based medicine and to provide fair treatment to everyone, and not different treatment, but equal treatment to everyone. So when we approach a patient, we should take measurements that take into account the difference of the patient. Specifically for transgender patients, and we are speaking, of course, about trans feminine or trans women patients requiring a breast enlargement, there are some important anatomical characteristics that we have to take into account. Of course, this population of patients, or I would say the majority of the population of the cohort of transgender patients, they have taken hormones, HRT, for a long time. And specifically, the guidelines advise, they don't say that it's mandatory, but they advise to take the hormones, have been on the hormones for at least 12 months to encourage the growth and the development of the breast. Most of the patients, it has been reported that 50 to 70% of the population of trans women are not happy with the size achieved and the breast development, despite have been on hormones for many years. And this is not just a matter of cosmetic. It's not just the size of the breast. It's how they feel about their chest and how congruent their chest looks according to the felt gender. And despite the breast has grown, of course, the HRT cannot change some anatomical characteristic of the patient. For example, transgender women tend to have broader shoulder and a broader chest. As well, the sternum, which is the chest bone, the one which is in the middle of the chest, tends to be more prominent than in cis patients and tends to be wider. As well, the nipples are different than those of cis patients. Despite the growth and the enlargement of the breast and the nipple, they tend to stay smaller than a cis female nipple, and they tend to have a more oval shape. As well, the distance between the nipple and the crease, the fold underneath the breast, is shorter than the one of the cis patients. The pec major, which is the muscle that you train, that you work out when you do your push-up, is also larger and thicker than the cis population. And as well, the skin is thicker, and the fascia, which is a sort of filming layer of tissue that envelops the muscle, is thicker as well. Despite they might sound like small differences, these differences are very important when we perform the surgery. because the final outcome will depend on these different anatomical characteristics that they need to be taken into account, discussed with the patient before making a surgical plan. If we replicate the techniques and the outcome and data that we have from cis population, probably we will be able to perform a breast enlargement, which is a bigger version of what the patient has. We're not performing a simple breast enlargement. We are performing a feminizing, gender-affirming, feminizing chest reconstruction. And to perform this type of surgery and to make the patient feeling more comfortable, more congruent with their own gender, and to make the chest appear more congruent as well, there are a few things that we need to take into account. There are a few things that we have to discuss to the patient. Otherwise, the final result might be just a slightly bigger version with not an ideal improvement in the congruence of the chest.
What can go wrong, or what is not ideal?
So surgery, breast enlargement is a pretty straightforward and routine procedure nowadays. It's safe, even if we do the same surgery that we perform in cis patient, but of course the outcome will be different. For example, patient might feel very self-conscious of the wide gap that they have between the breasts, and this might not look very feminine. And having a breast enlargement, committing to the surgery, taking downtime, going through a lot of stress of this process, paying a lot of money for them being left with an outcome that is not ideal, probably it can be quite upsetting. If we use, for example, the same type of implant, the same type of approach for cis patient, and we don't take into account the wide and the more prominent sternum chest bone at the center, patient again will end up with a bigger breast, but it might not feel very congruent with their gender identity. So to try to enhance the cleavage and to provide the patient with the best outcome possible, and the best outcome possible is the one that the patient feels comfortable with when we perform the surgery, we need to take few measures to try to address this characteristic and to provide patient with an outcome, which again is not cosmetic surgery, is not a simple breast enlargement, is not enlarging the boob, is creating a more feminine, a more gender congruent chest.
And what do you do?
For example, there are different techniques that we can offer to the patient. First, I have to explain that for breast enlargement, there's not only the option of using a prosthesis. There are different types of options. Of course, when someone speak about breast enlargement, we all think about big boobs. We all think about a huge piece of silicone that goes in the breast.
Like inflate a balloon, so simple.
Yeah, exactly. No, there are different techniques for breast enlargement. The prosthesis or silicone or saline filled implant is probably the most performed surgical technique nowadays, but it's not the only one. We can enlarge the breast or reconstruct the breast also with the own tissue of the patient. We have two different types of autologous augmentation or autologous breast reconstruction. The most simple is what we call fat grafting or fat transfer or lipofilling. What does it involve? You know that often patients have some areas of stubborn fat. They've tried diet, they've tried exercise, they struggle a lot, but with no much result. Plastic surgery becomes our friend to address these areas of stubborn fat through a technique called liposuction that probably most of you have heard of. Liposuction involves harvesting fat through small cannula, so through a very tiny pipe, harvesting this fat, fragmenting this fat, and then we can use this fat as a natural enhancer, as a natural filler to fill any area of the body, to restore volume or increase the volume of any area of the body. But fat is not just a filler, it's a natural filler. It's a, I will say, biological rich fluid. Why? Because fat contains adult staminal cells. So when we harvest the fat, we are not just harvesting fat cells. We are also harvesting growth factors, and we are also harvesting adipose-derived stem cells, which are adult stem cells. And this is what the project of my research in my PhD as well. So we can harvest the fat from areas of the body that is not particularly desired. We purify the fat, and then we can inject the fat as a natural enhancer. One option is to inject it to the breast, but we can also inject fat, for example, in scarring, in atrophic tissue, because fat has this growth factor and staminal cell that can help encourage the improvement of the tissue and the structural architecture of the tissue. Specifically for the breast, is used as a filler, and we can transfer fat from one area, from tummy, from the thigh, from anywhere, and we can inject it to the breast. Now, we are not able to inject as much fat as we want. When we harvest fat, the tissue around the fat that has been injected and has been transplanted need to provide adequate blood flow, adequate nutrients for that fat to survive. So if we inject too much fat, there's a disproportion, and the fat will not take. As well, not all the fat takes. Part of it is reabsorbed by the body. This is the natural physiology of any tissue. So it is estimated that 50 to 70% in the best scenario of the fat takes. So if we inject too much, it won't take. This results clinically in the fact that we cannot increase the size drastically if we are doing breast enlargement with just the fat. And sometimes patients might need more surgeries, more procedures, more sessions of fat grafting for increasing the chance for the fat to take and to increase the volume. We have also the option of using other tissue of the body rather than the fat to enhance the breast. These techniques are called free flaps, and they involve moving tissue from an area of the body to another. And this is a proper transplant, because while the graft needs to make the roots, as I said before, to grow, the flap is harvested with the roots, with the blood vessels, and we reconnect those vessels under the microscope to ensure that the flap survive. This type of surgery is performed mainly for breast reconstruction. It's a more complicated surgery. Also because to perform this surgery, we need quite big and obvious scar. So unless, aside few rare cases, is not a routine procedure that we offer for breast enlargement. And last technique that we have is a combination of what I described before. The hybrid breast augmentation couple the advantages of an implant with fat grafting. So the advantage of an implant is that the patient might have a significant increase in the size. The fat grafting instead has the advantage of acting as a natural filler, promoting breast growth and the healing of the tissues, and also to thicken the tissue, the natural tissue with the patient with the natural own tissues harvested from other area of the body of the patient. Now, if a trans woman wants a good size, a significant increase in the size, we need to use an implant. But not everyone is a good candidate for having an implant. For example, patient who did not experience a lot of breast growth in the chest, they might not be the best candidate for an implant, especially if we want to place the implant over the muscle to narrow the gap between the breast and enhance the cleavage. There are two ways of placing an implant, two main groups. There are different techniques, but there are two main families, of technique to perform a breast enlargement. We can either place the implant over the muscle or under the muscle. If we place the implant under the muscle, the implant will have more coverage because it will be protected in the upper pole by the muscle. But because, of course, we need to respect the anatomical boundaries, we are not able to place the implant very close together because the muscle attached at the side of the chest bone. And if the patient is a wide chest bone, of course, the implant will be quite to the side, quite lateral. And this might not give the best outcome, especially to a trans women, because we want to feminize the chest and reduce the gap and enhance the clip. In this case, for example, we can use an implant. If a patient is not a good candidate for having an implant over the muscle to enhance the feminine characteristic, hybrid technique could be a good option. Why? Because we are able to use a small size implant over the muscle and to thickening the tissue, the subcutaneous tissue, to provide adequate coverage to the implant. This way, the patient will have a very natural result, very soft. Part of the breast will be their own tissue, and they will be able as well to have an outcome that might feel more congruent with their gender identity.
Do you have a particular recipe that you recommend, or is it particularly dependent on the physiology?
There's a lot to discuss. We can make a series of podcasts just on this. Okay. So I will try to be more synthetic. So I will try to be brief and give you the most important information. So when we meet a patient at a consultation, we have to discuss the patient expectation. Of course, we have to discuss the medical history of the patient to see if there's any abnormality on the chest, any surgery performed before. We need to carefully discuss the patient, the expectation with the patient. Because, a lot of patients, cis or trans, doesn't matter, they come for a consultation for a cosmetic surgery or for gender-affirming surgery, and they bring with them testimonials from other patients, friends or people they saw on socials, showing their pictures and saying, I want exactly that same look. I want to look like this. And of course, it's our role to readjust the expectation of the patient because everyone is different. The anatomy is different, and the same type of implant, the same size, might look very different on either patient. So once I had the expectation of the patient, it's important to examine, conduct a physical examination of the chest of the patient, and also other areas if we are interested to do fat grafting, for example. And then taking measurements, because of course, if we are going to use an implant, we need to make sure that the implant size and the width, the height of the implant match the footprint and the characteristic of the chest. We want the patient to look in proportion. If we use a wider implant that doesn't match the footprint of the breast, it might look quite weird and might look not very natural. So we take measurements. We also take pictures because it's important to document the journey of a patient. And of course, these pictures are stored in a safe way and on our safe medical record system. And then we perform a sizing test with the patient. So we let the patient trying sizing implants in a bra if patient believes that they want an implant, and I agree that probably is the best option for them. We ask patients to try the sizing implant in a sports bra to help them envision how or what the final size will be. This test doesn't give the idea of the final shape, it just gives an idea of the final body. Once we have done all this, I have all the information that I need, and I can discuss with the patient what are the best options. And I'll try to make it simple because, of course, there are many different factors that I have to consider, but I don't want to make you fall asleep with all this technicality. Basically, if a patient is asking for a good size, a significant improvement in the size, increase in the size, of course, we need to advise him. But if patient wants just a touch-up or half cup size or just 1 cup size and something that is very natural, we can use the fat grafting, and it is the first criteria. Then, if the patient has a lot of tissue or a good amount of tissue on the chest, so if the patient develops some breast growth through the HRT, then according to the expectation and the size that the patient wants, I might advise to place the implant over the muscle, because the thickness of the tissue, the quality of the tissue will will ensure that the implant will be covered by the tissue and won't become exposed. The risk of placing a big implant under the skin, under the breast tissue, without an adequate coverage, without enough tissue to cover the implant, is that the implant might become visible over time through the skin, and of course, it might not feel very natural and might not be very comfortable for the patient. And as well, if the implant is too big and the skin has not the right elasticity to stretch and accommodate the implant, this might cause serious complication, because the implant might thin the skin too much, the implant might get exposed, causing infection that will lead eventually for the implant to be removed and the patient to be hospitalized to treat the infection. Instead, if the patient doesn't have a lot of tissue on the breast, if the patient didn't develop enough tissue, and they want a moderate size, I advise a dual plane technique. Dual plane technique means that the implant will be covered by a plane, so we will make room for the implant. We will make what we call a pocket, and the upper part of the pocket will be covered by the pectoralis major muscle. The lower part of the implant will be covered by the breast tissue. Now, I have patients that would like to have a good size. They would like to have a more feminine chest, to reduce the gap between the breasts, to enhance the cleavage, and to feel more comfortable with the result. But if they don't have enough tissue on the chest, and I feel that they won't be happy with the reconstruction under the muscle, with an implant placed under the muscle, because it won't address the characteristic that they don't feel comfortable with, then I discuss with the patient, the option to use a combined technique, hybrid breast augmentation. So I will use an implant to give the volume, enough size for the patient to feel comfortable with their chest. But I will also use some fat tissue harvested from any areas of the body, if it's available, of course, to give more coverage, to increase the thickness of the subcutaneous tissue, so the skin and the breast, and to reduce the risk for the implant to become more visible, while enhancing the cleavage, enhancing the upper pole, and give a more natural and gentle shape.
Is that a relatively new procedure to the UK, the fat grafting? Because when I've had a BA and I didn't have that option, and I would have loved to have taken that option.
So liposuction and fat grafting have been around for long.
Yeah.
Now, the coupling, combining both the procedure is something more recent. It's something that has been started in the field more recently.
Yeah.
Especially because the technologies that we have available, they are different. They are evolving as well. The implants, the breast implants, and I'm speaking specifically for silicone implants, not saline implants. The silicone implants have evolved a lot over the past, I would say, 10 years. We have implants nowadays that they reduce the reaction of the body against the implant, so they cause less inflammation, and they tend to be less visible. So recently, this new technique, which combines fat grafting and breast enlargement, has been developed, and I absolutely have embraced it. Coming from a reconstructive background, of course, I try to use different techniques to give the best option, the best outcome, and using some tissue that is the own tissue of the patient in combination with the breast enlargement, I think it is a great idea. It's a technique that borrows some aspect from reconstructive surgery, and it works perfectly. It's brilliant in my opinion.
Cool. Does that impact the recovery time? Do the different procedures have different recovery times?
Yes. So overall, the breast enlargement doesn't have a long recovery. What I tell to my patient is that the pain should be bearable. If it's unbearable, there's a problem. There's something going on. The pain should be bearable. It's more that the chest will feel sore, and it's more the tightness. If we are using an implant, the implant is a big foreign body under the skin or under the muscle. And of course, this will stretch the skin and put pressure on the chest. So it's more the tightness rather than the pain. And what my patients report is like they feel like an elephant is sitting on their chest. But it's all bearable. The recovery time for a straightforward breast enlargement overall is in terms of pain and go back to work. So the downtime can be a few days or a couple of weeks. Really depends on the pain threshold of the patient. But normally my patient, in a week time on average, they are all recovered. Now, if we are performing over the muscle breast and over the muscle breast augmentation, so a subfascial or subglandular breast augmentation, because we're not detaching, we're not disturbing the muscle, we're not detaching it from its attachment to the sternum bone or to the costal bone. We don't detach it much from the sternum. Then it might be slightly more uncomfortable, just because there's a lot of innervation, there's a lot of nerves, there's a lot of sensitivity there. If we perform the liposuction, if we perform the fat grafting in combination with the breast enlargement, the recovery, of course, will depend mainly on the liposuction aspect of the technique. It sounds like, liposuction, we see a lot of stories on TV, we see a lot of stories on social media, in and out surgery, lunchtime surgery. So they just go to the clinic. It's all under local anesthesia. They inject a bit of local anesthesia, go out, they put makeup on, they go back to work, it's fine. No, the reality is that liposuction can be very painful. So patient who had big surgery, a big breast surgery, big changes might not have any pain on the breast or minimal pain on the breast, and instead the liposuction might be more tender. Liposuction is not the most gentle technique. It involves a lot of strength to harvest the fat out through the cannula. Of course, the patient anyway, don't get me wrong, the patient is fully anesthetized, either an anesthesia or local anesthesia, so they shouldn't feel much. But after that, it's quite painful, it's quite tender. So if we perform liposuction, the recovery time might be slightly longer. Patient might need a couple of weeks to be fully up and about and to feel comfortable to go back to work. But to try to enhance the recovery of my patients, I develop for liposuction or patient undergoing fat grafting, any surgery involving a stage of liposuction, I developed this enhanced protocol that gives some pre-medication to the patient from the day before the procedure to prepare them for the surgery. And I found that this protocol has increased the threshold of the pain of my patient, and they feel much better. I had a problem recently with the clinic. There was not a medication, and some of my patients didn't receive this pre-medication before the surgery. I must say that they struggle a lot, and it was a surprise. So with this type of pre-medication approach, I found that the recovery might be better or smoother.
What sort of medication is it?
So we give you painkillers from the day before of the surgery. And there are some studies that have showed that this preconditioning might influence the recovery of the patient.
Oh, interesting.
With all of the additional complexities involved with trans patients, the things you must be aware of, not necessarily the surgery being more complex, but what you need to know beforehand, would you recommend any trans person go to a surgeon who is experienced in trans surgery?
I would recommend my patients to do their own research, to look up for the CV and the profile of the surgeons, and make sure that they have experience in gender surgery or gender healthcare. Transgender patients, they have specific needs and they have specific characteristics, and it's important to be treated by someone who is not an expert, but at least has some experience in the field. It's not me saying that. Is the international guidelines as well, the WPATH guidelines. One of the recommendations of the guidelines is that whoever perform any gender surgery should have at least 1 year experience in the field. And this is not only to ensure that the patient will achieve the best surgical outcome, but also because surgery is a journey of trust. Someone who works in the field, someone who knows this cohort of patient, might be more empathetic, might be more supportive, and might have the skills that will make the journey and the recovery of the patient better. Surgery outcome depends on the surgeon expertise, depends on the technique, depends on the surgery that has been performed, depends on many different factors: the genetics of the patient, the healing, the compliance of the patient with the postoperative care and the postoperative instructions. But it also depends on the trust that has been developed with the surgeon. If patient has an expectation which is unrealistic, and is not what we would recommend, we have the duty of saying no, and we need to establish a trust relationship. Any patient who can develop a complication, because surgery is always a gamble. There's always a chance that the things might go wrong, might go differently than what we expected. If there's this trust and the patient has the right skills and the right experience in transgender care, I believe that the patient will recover faster, and even if there's a complication, they will be able to overcome any issue. If the trust is not there, if the expertise is not there, patient might have a more difficult journey.
What would you say to a surgeon who asked their patient the day before the surgery, if when we get you open, we can fit a larger one in there, would you like us to give it a try?
Absolutely, I don't agree, and I will advise my patients to question this attitude. We have a rigorous medical and surgical consent process.
Yeah.
And this is part of our duty. This is part of our ethical duty and our profession. Every time we consult the patient has the right to take all the information, process all this information, take on the information, process all this information, absorb the information, and make a full informed choice. That's why I believe that every patient should have what we call cooling off period. Any patient who has been consulted should have at least, according to the practice and the guidelines, at least 2 weeks to think about the options that have been discussed, to think about the plan. Patients should never feel rushed, should never feel unheard. So if someone tries to change the plan right before the surgery or a few days before the surgery, I wouldn't feel comfortable with it, because patient didn't have the time to think about the options. They might regret it. They might have, have said yes just because they felt rushed. They felt that, there was the chance that the surgery might get cancelled if they wouldn't agree with the surgeon. So absolutely, this is not the right attitude. And I think that is quite unprofessional as well.
But I suppose it means you wouldn't recommend anyone engage in medical tourism, because you don't really, with the scheduling, have the opportunity.
You don't have that 2-week cooling off.
No, I received requests from international patients. I'm happy to offer them a virtual consultation just for introduction, just to chat, but then they will have to attend in person, and they will have to stay at least two weeks before any surgery. Which of course makes things more difficult, might decrease the chance for me to get more patients, but I prefer performing less safe surgeries rather than a huge volume of surgeries.
Yeah. So breast augmentation for trans women is not available on the NHS, and I take it that's because it's categorised as a cosmetic procedure. But in your opinion, breast augmentation for trans people isn't cosmetic, it's life completing. So do you think they need to recategorise that and make it available on the NHS?
That's a very good question, and opens a lot of doubts and a lot of things to consider.
Yeah, because obviously that's the difference between the trans women and the cis women. Cis women are able to get breast augmentation without having letters from psychologists, yet trans people, because it's not a cosmetic procedure, need to have those letters.
That's correct.
Yeah.
First, I don't think that breast enlargement, any type of breast enlargement, is always a cosmetic procedure. Either if it's for a cis or for a trans woman. There are women who have undeveloped breast tissue, and I'm not speaking about patients who have small boobs. I'm speaking about patients where breast didn't develop much or didn't develop in the average way, I would say. So there are different conditions. One is called Poland syndrome, where a patient during the birth and childhood didn't develop either one breast or both breast or other structures of the chest. As well, there's another condition called tubular breast. In tubular breast, patient didn't fully develop the breast tissue. Cis patient, I'm speaking about cis patient, of course. So, characteristic of tubular breast is an undeveloped breast. In these two, and there are other conditions, but for example, in these two conditions that some cis women might present, of course, performing a breast enlargement is not cosmetic, it's proper reconstructive surgery. Imagine being a very young lady with, as well, for example, tubular breast, has often very big asymmetry, with one side maybe being an A cup and the other side being a C or a D. So imagine being a very young lady and not being able to find clothes to fit or bra to fit the breast because they are different size or there's no tissue there. Imagine the struggle in the social life of this patient and in also the sexual life of the patient. They don't feel congruent and they don't feel well with their breast. And this, of course, can cause mass mental health issue. Imagine how upsetting it can be. And, trans population knows better than anyone else how does it feel to be in a body that is not common.
Yeah.
So, also for cis patients, some breast augmentations are not simple cosmetic surgery. As well, for transgender patients, breast enlargement is not a cosmetic procedure, it's a proper chest reconstructive procedure. In my opinion, I think that a fair healthcare system should offer the option of having chest reconstruction in patients who need. The problem is the criteria, is to find the right criteria to discriminate between those patients who really need it and those who don't. Because otherwise, if we perform any type of surgery, any breast augmentation to any patient, of course, this might become a bit overwhelming and unfair, and it might be a big burden for the healthcare system that is already under a lot of pressure.
Yeah.
So in my opinion, breast enlargement overall shouldn't be considered always a cosmetic procedure. Now, finding the criteria, finding the resources is a big problem that might take a day-long discussion.
But some breast augmentation can be done on NHS under special circumstances, right?
Correct.
Yeah. How does one access the special? What special circumstances would cover that?
There's a way to try to apply for some funding for any type of surgery that is not normally funded by the NHS under specific circumstances. So if the patient fulfills some criteria and if the patient provides evidence that this surgery, of course, will impact on their life and is not just an elective surgery. This system, this pathway, involves submitting an IFR, individual funding request. The process is very tedious, is long, takes a lot of evidence, and not always, of course, if an individual submits an application, the application, of course, is approved. In this form that should be completed by professional or any doctor, and normally it's the GP who can perform this type of form because it's the person that probably knows better the patient, or it hopes he knows the patient at least, and is the best one that have all the information, a comprehensive history for the patient. In this form, the GP, of course, guided by the patient experience, needs to provide evidence to support the application and explain why in that particular condition the surgery will make a difference. This application then will be submitted and will be reviewed by a committee that discretionally can decide if the application can be approved or not.
I would imagine in the current climate, there's not many GPs that would actually advise and fill out that form for you, given that most GPs don't want to indulge in trans healthcare. They don't even want to prescribe blood tests or prescriptions.
I know, and we can support patients. If a patient comes from the consultation and if they want to take the route to submit an IFR, we can send the GP to the GP letter to provide all the information and try to make this process easier for them.
I guess it's quite rare that happens, though, right? The IFR.
Yeah, normally I think 20 or 30% of the application then is not just for gender surgery. This IFR is for any procedure or any medical intervention in the NHS.
Right.
See that the amount and the chance for all these requests to go through.
Phoebe, do you have any more questions? Because we're getting a bit short on time.
Yeah, I do have a question. When you go back to your hometown, your place of birth in the bottom of the heel of the boot in Italy, what sort of reception do you get from people when they learn that you perform gender-affirming care?
So I might say that thanks to social media and internet nowadays, all the information are available to everyone.
Yeah.
So I have people from my hometown, my cousins, my relatives, they all follow me on my socials. I have a professional Instagram page, one for my private practice, one for cis patient, and one dedicated to transgender patients. So there was no intention for me to hide it, but of course it's on the public domain. And I must say that I have a big family. You know how family in South Italy are. My father has 9 between siblings, between brothers and sisters. My mom has 7. And every family has an average of 3 kids. So imagine the quantity of people, the number of people. So I realized that, that I have a lot of cousins that I never met. They follow me on Instagram. They see whatever I do. And I must say that I have received a lot of appreciation and a lot of support, which
that's nice.
Was a surprise. A lot of people, of course, they realize what this surgery entails, really, what was the difference that can make. And they're very supportive because, they have someone who, instead of staying in his hometown, it would be lovely. Don't get me wrong. I would love to stay there. But, he's trying to challenge himself and go abroad and build something different. So I think that they are very proud of what I'm doing. I cannot hide that, of course, I will receive, and I have received some critics. For those who will criticize what I'm doing, of course, they are absolutely entitled to give their opinion. But for those who already gave me negative feedback or say something not nice, I invite them to come visit me in London. I will host all of them, but come and visit me in London, spend a day with me, and see with their own eyes what this surgery is and what this surgery means for patients. Waking up after a surgery and seeing a patient that is not just relieved for having the surgery, but is relieved because he's getting his life back, is given the option to live as a complete individual. The smile on the face, that kindness, the difference that this make is absolutely unbelievable. And I think that that's the best argument that I could use for those people who are criticizing or have criticized my job.
Oh, that was beautifully said.
Thank you.
Did you know any trans people growing up in the village? How many were there?
No,
No.
Not even the people, invece trans people.
Yeah. Thank you so much for your time. That's very generous of you.
It's been an absolute joy talking to you. And tell all your surgical friends how nice the experience was, and tell them to come and talk to us.
Thank you. Thank you again.
Thank you, Giuseppe. Bye-bye.
Bye.
So what did you take away from that, Phoebes?
Oh, there was one thing that really, really struck me. And there was such a lot in this interview. It was information-packed. Mm-hmm. But when I was having my BA in Turkey, this crazy thing happened where at the last-minute consult with the surgeon, he ushered me into his office and asked me the day before my surgery, if you want to go bigger, do you want to? And we had already been through the fittings that you do, and I was really happy with what I decided upon. But in that moment, I thought, well, how often am I going to do this? It's not like I'm ever going to come back and say, let's go bigger, because, well, it's costly, isn't it?
Yeah, bigger's better, right?
Yeah, right. And I thought, well, what's there to lose? And so we went ahead and did it. And honestly, the result in that feeling of being rushed through, what it's left me with is feeling like I'm just a bit too big. I was happy with the size I was. But I can't see myself having a reduction now. And others are very nice about it. But for me, I think they're just a little too large, and I felt rushed. And I loved the idea that you take 2 weeks to think.
Well, they look pretty good from where I'm sitting.
Thank you. What about you?
For me, it's about the fat transfer.
Yeah.
When I had my BA, it was never on the table. I exclusively looked at a couple of companies in the UK, and never was fat transfer ever mentioned.
Yeah.
And as a result of that, you could park a small car between my boobs.
Oh, no.
So I wish that fat transfer had been a thing.
Yeah.
I mean, you had it in Turkey.
Yeah.
And you've got a much better cleavage than I have. So,
right.
Yeah, you might not be happy with your boobs, but I'm so jealous for your cleavage.
Oh. Isn't that the way, though, with all things transitioning? We get bits, but we don't get everything we want because we actually weren't born with everything we want anyway. It's all compromises in the end, but we do the best we can.
Yeah. Anyway, it was a great interview. Very informative.
Yeah.
Should we wrap things up?
Sure. Yeah, so that's it for this episode. We will be talking with the amazing transpiration Danny St. James in our next episode. But meanwhile, we want to thank you, our listeners, for tuning in and being part of our community. If you want to connect with us further, please visit our website, redandfreckles.com, where you can keep up to date on all things red and freckly.
And you can also follow us on Blue Sky, Threads, Instagram and Facebook, but not Twitter. We use the handle @Two Damp Trans on all of our platforms, so you can DM us if you have any questions or topics you'd like us to discuss.
And please don't forget to subscribe and rate us, if you will, on Spotify, Apple, YouTube, or wherever you listen to podcasts. We're on all the popular platforms.
And as always, even on some of the unpopular ones too.
We appreciate your feedback and support.
So until next time, remember you are valid.
You are beautiful.
And you are transcending boundaries.
Da-da-da-da-da-da-da-da.